95% of the sickle cell disease in the United States is African American and 5% from certain Mediterranean areas which have certain kinds of malaria. Now, who did all this work? Jim Neal. And Jim is a great guy. He's retired now. He's an old man. But he was a real smart guy. And when he was in the Army for the Second World War in North Africa, and, and slightly farther down in Africa, he says, there's something not right about this sickle cell thing. If all of our theories are correct, you ought to select against it and get it out of the population. Well, he's the guy who actually put the blood under the microscope and said, I think that they can't insist the malaria in sickled cells. She said, well, that's pretty good. So he divided them up into 3 groups and said, you've got people, there's an A chain and a B chain, and you got 2 of them, 4 chains. So AA, BB is what we usually are. But the A's don't count. It's just the B chains. So you can be B, S, B, and sickle cell, okay? Or you can be sickle cell, or you could be BB. Just normal, that, and that. That's it. What's the difference? 1 loci, just 1 on the DNA chain that substitutes, I always forget, it's thymine for adenine in 1 spot. That's what does it. And if you do that, and you live in an endemic area for not falciparum, but malariae, what happens is they can't get in there. Now, is it great hemoglobin? No. Is it sort of okay? Yes. And if you have trait, you're not too bad, because a lot of your stuff is perfectly good. And you only need so much oxygen carrying capacity. It's when you have disease, both of them, that you got trouble. So Neal figured this all out, and Jim Neal, and it was a very interesting thing when it came out, and it helped to defend why certain traits. This, by the way, was the disease entity, which they talked about selective advantage, and why certain things that seem bizarre stay in any species because of things like these environmental areas where they succeed. And so this is a prototype for a lot of other diseases. Suffice it to say, in the U.S. at this point in time, about 1 in every 500 to 600 African Americans have disease. 1 in 5 to 600. That means, is it between 80 and 90,000 people in the country? Somewhere in that line. And so if you work in an area, I've worked in lots of different hospitals in my career. I worked, my last part of my shifts were in Chelsea, Michigan. I didn't see anybody with sickle cell for 5 years, not one. I called Child Protective Services once in 5 years. 20 miles away was Bayer Hospital, where I was chief for 22 years. I had a little cadre of sickle cell people who were friends of mine by the time I left. We knew each other. Ralph, what's the deal? Usual. Okay, lay down. Would I put them through anything? No, I examined them to make sure they didn't have another infection, got their medicine going, got them out. Why? Because what good would it do for me to say, no, you don't have pain? Does anybody here have a painometer? I'd love to have a painometer. Get me a painometer. I don't care, as a matter of fact. It's interesting in how we behave as individuals. It's the adjective we use with pain. Because if I said to you they have 2nd-degree burn pain, morphine, not a problem. They have cancer pain. Oh my God. You're not even asking where the cancer is. It could be a basal cell on their nose. But if you've got cancer pain, now all questioning stops, right? All intelligent discussion stops. We just give them the pain medicine, and we feel better. It's when we don't have an adjective to go with it that bothers us. So I would just say this, when you're dealing with sickle cell, just assume they have pain. Because if they actually have the disease, they do have pain. There's a very nice Article 1. And I'm going to point out, as I always do, I will be giving you some 4-star papers, something to circle and actually worth reading. First one is an okay study, but it's going to lead to the next study. This is the one where they ask, how severe is the pain? So without actually being in the emergency department at the moment for pain, they gathered up their regulars and just said this. How often do you have pain? 55% they said they had pain every day. 29% they have pain, a lot of the time, but some days pain-free, and 14% said they hardly ever had pain. Relatively rare for them. And these are people, understand, they're not trait, they're disease. So there is a spectrum of disease like there is in all of us, that it didn't matter what the genetics were, some did, some didn't. Article 2 is a 4-star article. It's worth looking at. Because this has the comparison, by the way, it's the same group of patients who were in the first article. Same authors, you know the rule in academic medicine. 1 patient, 1 paper. 2 patients, that's 4 papers. It's the multiple. It's that factor. Anyway, comparison of high and low emergency department utilization. Who came in and who didn't? Well, they looked at this same group of patients over about 3 years. Some people came in 0 times. 0. One guy came in 125 times. Now, would that be a little suspicious? I'm just asking you now. If the nurse said, he's in here for his 124th visit, you and I have something called hot button personalities. There are things that are presented to us which stop all rational thought. A hot button. Here, this damn drug seeker's back again. Now you've stopped thinking. Now you're mad. Now you're thinking, oh, they're going to think I'm a candy man if they get any pain medicine out of me. You start to punish yourself for behaviors. There's all kinds of these. Whether you realize it or not, most emergency doctors are prejudiced. But it's not about race. It's about weight. You realize when they do studies in emergency doctors, oh, that fat bitch is back again. You don't like thin people? Yeah, shit, shut up. Yeah, see, at least you can find things on them, But you and I all have hot buttons. And as I tell the residents, your job is to discover your hot button list. Because you have them. And every time you hit a hot button list, just step in the hallway and say, Greg, slap myself. Go, Greg. You're not going to let your hot button interfere with intelligent medical care. You just remind yourself. And that's the best thing you can do, particularly with these folks. So what they found out was there's this huge spectrum of who came in. They all had the disease. They were homozygous for the disease, and yet it was quite different in the presentation. It's a good paper to read, just understanding that the variation in the disease. Question 2: do physicians believe sickle cell patients have pain? Well, very interesting. In one paper, they showed a video to people about be sensitive, be nice. I always thought, you ever been in a department where they have these buttons that say, we care? Did you ever see that? Yeah. My feeling is if you need to wear a button, you got a lot of other problems, okay? If you actually have to read the button, because most of them ought to have a button that says, I don't give a shit, okay? And no whining, okay? That's what they all get. Yeah, well, in any event, what this is a very good paper from Internal Medicine Journal, May 2011. And so they gave this to residents and nurses, and then see if it actually made a little difference. Well, it's always good. You see, here's the problem with this kind of training. We can show it to you, then see what you do for the next month with people. The next thing to do is to see what you do in 6 months or 8 months or 10 months or something like that. Maybe it helped a little. But you know what? If your mama didn't give you compassion, it's very hard to educate it into you. It's very, very difficult. There's a comparison here in 4 between analgesic management for these patients, and they compared the pain management in sickle cell patients with patients who have renal colic. Now, as Diane will tell you, I know something about renal colic. It's not a good thing. But sickle cell isn't a good thing either, and what they found out was in this 263 patients, in the study, it's not huge, but what they found out was, as a group, renal colic patients were triaged at a much higher level. Their pain was more important. They got their pain medicine 30 minutes earlier. They got repained medicine more often. Well, wait a minute, they both had pain. What was the difference? Why would you think one's in worse pain than the other pain? I don't know why, but clearly medical people did things. So here's the other thing is 16% of the people with sickle cell were treated orally. Come on. How many people do you treat in an emergency department? If you've gone to the trouble of starting a needle in the vein, why would you have to go through the alimentary canal to get to where you want to give pain medicine? Doesn't make any sense to me, folks. But anyway, think about it. Article 5, about the same conclusion. Article 6, same conclusion. They actually looked, Article 6, looked again at ED management, and they asked the question about time intervals on pain management. How much time was an IV, that sort of thing. It's a repeated story that if you actually came in and can prove it to me that you've got pain, you know, an arrow through the head, pretty much ER doc said, yeah, that's got to be painful. What about a broken leg? That's how they faking a broken leg, okay? We're comfortable with that when we can't actually localize and watch and see the pain. As in sickle cell disease, we're not comfortable with it. Now, there's a series of articles, 8, 9, 10, 11, all say the same thing. So whenever you ask this question, should we as a department have a protocol for treating sickle cell disease, the answer is yes, we should. Why? Because it takes away the variability doctor to doctor. What these people said, and there are 4 articles here, and they conclude the exact same thing. When you start on a protocol, bang them good, put them on a drip, these people do better. And here's the best part. They got out faster, okay, they used less overall drug, and they were happier with their care. See, I'd like them to leave happy too. If you're pretending that if we don't treat them right, they'll go someplace else, you're just wrong. You may be the neighborhood hospital. They're coming back, so they might as well come back as your friend. As I said, I developed about 20 of these people we could call each other by name, by first name. Why? Because they had a disease that wasn't going to go away. And by the way, I wasn't going to go away either. So they were going to be back. Now, the guy who did the chapter is Al Sacchetti, a great guy, great person. And he's given us some things here which we really need to look at. He gave you a list of the specific end organs that get worse. He gave you a list of the susceptibility to infections. These people do get worse. When they come in with something, it is a bigger deal. And lastly, the clinical infection spectrum, like, do they get pneumonia? Yes, but they get worse pneumonia. Do they get cholecystitis? Yes, worse. More likely to have it taken out, that sort of thing. Read those, sort of internalize those. I think those are absolutely worth looking at. a series of things here that say, is the management of sickle cell better at sort of specialized hospital? Picture the places you're going to treat sickle cell. Urban, poor, right? Teaching hospitals. So we should be better at it, right? Because they do a lot of it. If you do a lot of it, that's the theory in medicine. If you're not doing 250 bypasses a year, don't be doing any of them at all. Send them someplace else. Well, but we don't feel that way about sickle cell patients. We do a lot of them. Did they do any better? No, they didn't. They didn't do better at all, and we need to kind of keep that one in mind. Okay, some arguments in pain management in sickle cell. There's a group who said, should we bring back Demerol? Why? Because some people seem to like it better. Because there was, a euphoric effect and things like that. I think this is a crazy debate. Article 12 and Article 13 fight with each other. Article 13 is the one that suggests, this is a 2008 article, it's preferred by the patients. It blocks side effects. The serotonin effect is weak, all this kind of stuff. The intelligent response to that is Article 12, which talks about why meperidine, why Demerol should not be used. And I think in general, meperidine these days is a drug in search of a disease. I have no idea why we'd use it anymore. I just don't know why. If you have Dilaudid, if you have morphine, I don't know what you're doing with it. And don't get sucked into this thinking. What about Tramadol? Another product that as I watched the ads on TV and stuff like that, and in the journals, I kept thinking, what am I giving this for? Well, they did a study looking at Tramadol versus meperidine, as a matter of fact, in sickle cell disease crisis. And basically what they said is Tramadol is probably like giving them a placebo. It doesn't do anything. Now, I want you to remember that sickle cell crisis is tiny arterioles at this is end organ disease. What are some of the organs in the body that have the most nerve endings? The periosteum of the bone and the central core of the bone. These people get a disease, a pain. When I was a first year, I often had to take care of people with metastatic bone cancer. It was the worst thing I'd ever seen in my entire life. I snowed those people to the point of unbelievability. Did they die a day earlier? Yeah, probably. Did I give a shit? No. It was the nicest thing I ever did to anybody. But sickle cell patients do have their pain in the area of the periosteum and that sort of thing. Very, very tender. What's the best way to administer the opiates? Well, that's pretty straightforward. You give it IV, but if you get the chance, everybody now in pain management is saying, let's say you know Joe, and he usually hangs around there for a long time. Just start self-administered pain medicine. Have a button they push. Now, there's always that person, who's flaming, who says, well, that's like feeding the bears candy and all this. No, it's not. It's not. They used less medicine when they gave it to themselves. 1/2 as much pain medicine. Why? Because if you're in control of pain, one of the principal reinforcers of pain, when you put out your own pain medicines in your head, a reinforcer is when you have control of pain, you're not afraid of it. You'll put up with a little, it's a little irritating, not bad. If you don't know that it isn't going to go on to get worse, what do you want? More of it now. The other thing is, in emergency departments, the big complaint is nurses don't want to set it up. And the truth is, it's less total nursing work if you set up the drip and the button, because then there aren't people asking 10 times, for pain medicine. I think this is the way to go. I think if you have a lot of these patients, make sure the nurses are trained in self-administration of the medication. It's not that hard, right? Well, tell my nursing staff, will you do that? Tell them to undress the patients too. Would you do that?
There's like a new regulation on this apparently. We used to do it, and
Yep.
now we can't do it anymore.
Well, that's not right. It's gone in the wrong direction then, because it really needs to be done. When we look at anesthesia, the next two articles dealt with anesthesia in children. And you know, there's a lot of 7-year-old drug seekers who are also sickle cell disease patients, right? Now, bottom line again, is you're going to want to treat them aggressively, IV. Article 16 has some doses in it. And again, they reduce the stay in kids. Listen to this. From 2 days to 0.9 days. 2 days, 0.9 days. Hit them hard, hit them fast, hit them big, let them control it, and get them gone. I think this is straight. I think this is straightforward. Patients always do better if you give them a choice. I would give them a choice. Yeah, right? If you're going to torture somebody, say, do you want malignant dwarfs or do you want bamboo shoots under your nails? Whichever one you want. Well, what they've said is, you know, do you want, did you do better with the Dilaudid? Did you do better with the morphine? You're going to be in control of it. And here's the phrase I like best. We will take care of you and we will take away the pain. I have more pain medicine than you have pain. I have more pain medicine than you have pain. Be comforted by that. I will make you feel well. Humans are 30 to 40% placebo reactors. They want to know that somebody cares about their pain. Just do that. You can't go wrong with that philosophy. Article 17, 2004 is again the controlled pump series. Again, this is for kids. And people say, well, it's okay with an adult. But you certainly can't put an 11-year-old in charge. Yes, you can, because you put a time lockout on. You know, you type in a time lockout. You can't push the button again for another 24 minutes or 32 minutes or whatever you put the thing in. The kids, again, used less tonal medicine, stayed less time. This is real simple. This is just gut-level stuff. Article 18 again goes back to the question of self-administered medication. And again, it's a small study, but it says the exact same thing. You notice we've combed the literature. I can't find, Rick Buchanan can't find the study that says they use more pain medicine, they stayed longer. There is no study like that. So I think the vector of this force is obvious. Hit them hard, drip it in, or let them push it in, and let them decide. And you always know with your 20 or 30 sicklers who you're friends with, they'll just look at you and say, Doc, I'm ready to go home now. And when they tell you that, you know what? They're right. I can't monitor their pain. They monitor their pain. And I think that's a perfectly reasonable way to go. The other thing is you'll always have, like in certain disease groups, my experienced asthma patients will say, it's not going in the right direction. This is going to be an admission. And whenever they say that, they're right. Why? Because they're the expert at their own body. The sickle cell patients, I think, are the expert at their own body. All right, we are going to take a break for 15 minutes. Come on back.